I'm Dr. Chi. Welcome back to Diabetic Profiles. Today's episode is about hospice and wounds. So, in wound care, we're trained to heal, close, offload, debride, graft, and save limbs. But in hospice, it's a little bit of a different question. What if healing is no longer possible and it's about comfort? Comfort becomes the treatment plan. So it's not about giving up in hospice at all, in my opinion. This episode is not about that, but it's about shifting goals, honoring the physiology, and protecting the dignity of the patient at the end of their life. Because here's the truth. No one really tells you early enough, but some wounds are not failure of care. Some wounds are actually signs of the body shutting down. But we have to respect and treat every patient with dignity and still give them the proper care, in my opinion. So, what is hospice? Hospice is defined, they always used to say, call it comfort care. Hospice care is comfort focused care for patients with a life expectancy of 6 months or less, approximately. Decision to stop curative care or aggressive treatments, a focus on the quality of life of the patient's symptom relief and the dignity of the patient. So, hospice is not saying there's no care, there's no wound care, there's neglect or euthanasia. That's not hospice, like we said. Hospice is about pain control, symptom management, emotional and spiritual support, family support, and ethical clarity. So, how does wound care change when it comes to hospice? So, traditional wound care goals are wound closure, granulation tissue, infection eradication, limb salvage, and surgical correction. In hospice, wound care goals for hospice is comfort, odor control, exudate management, pain reduction, skin protection, and psychological peace. In hospice, a stable wound is a success, even if the wound doesn't close fully. So, let's talk a little bit about the physiology of dying skin. So, as the body shuts down, the blood is redirected to the vital organs. The skin becomes ischemic, protein synthesis declines, immune response weakens, and cell turnover slows down dramatically. So, like we always said, the skin is an organ. And like the heart, the lungs, and the kidneys, skin can fail too. And this is where clinicians must understand skin failure, end of life skin changes, and then unavoidable pressure injuries. So, there's some common types of wounds that people see usually in patients that are in hospice. One is called the Kennedy terminal ulcer. So, with this ulcer, it's a rapid onset. It often appears hours to days before death. It's butterfly and pear shaped. It's dark and necrotic in its appearance and is not preventable. So, this type of ulcer, the Kennedy terminal ulcer, this is not a failure of repositioning. It's kind of a marker of imminent death. Next, unavoidable pressure injuries, despite the patient being turned, despite having specialty mattresses, despite being in a skilled care facility, sometimes patients get pressure ulcers because of hypotension, cachexia, vasopressors, or having multi organ failure. Next are ischemic and gangrenous wounds, which are common in patients that have advanced diabetes, patients who have peripheral arterial disease, patients who have heart failure, patients who have renal failure. In hospice, there's no revascularization, there's no amputation unless pain or sepsis mandates, okay? And then there's no gangrene. Dry gangrene is often, like I said, dry gangrene in hospice is often left intact, okay? Because the whole thing is treating the physiology and comfort care and pain reduction. So, and giving the patient dignity. Next common wound that you see with patients that are in hospice is malignant, possibly, or fungating tumor wounds. So these wounds bleed, they have an odor, they can get necrotic, they can have exudate, and honestly, they can cause emotional distress. The primary goal for these type of wounds also is odor control. Odor control is one of the big ones. Bleeding control, dressing simplicity, and psychological protection, because you don't want this wound to mentally disrupt the patient, to be honest. So, pain control, exudate control, and odor control. So, when it comes to pain control, especially when it comes to hospice, minimize the dressing changes, because a lot of patients, especially with who have critical limb ischemia, we're not talking about neglect now. Okay, we're not talking about that. But if the dressing changes are extremely painful for the patient, some people like to do, remember I said about aggressive dressing change in frequency? Let's say, oh, the patient will benefit from it being 3 times a week or 4 times a week, things like that. But if it causes the patient significant amount of pain, we're not saying we want it to get infected. Okay, of course not. But to minimize it, let's find the minimum amount that will allow us to still have a healthy, stable wound, but do not cause them significant in pain. I don't want the patient to be afraid every day, be like, "Oh my gosh, they're gonna change my wound again." It's so painful, especially patients who have critical limb ischemia. Critical limb ischemia is one of the most painful conditions a patient can have, in my opinion. So, like I said, with pain control, we're trying to minimize the dressing changes. We're trying non-heroin dressings are very helpful for those. Pre-medicating the patient before the wound care dressing would be helpful. Avoid sharp debridement, to be honest, and you can use topical anesthesia products when appropriate. Next is odor control. So odors, if anybody hasn't been to a hospice, they're, anywhere, especially when patients are in debilitating positions, they're not the healthiest. Especially also, you don't want neglect at all, okay? Because patients' wounds can cause an odor even if it's getting dressed every day, depending on the accident. So, odor is one of the most distressing symptoms for family. So, you can use tools like metronidazole, charcoal dressings, baking soda, odor absorbers, room ventilations, things like that. And now exudate management, high absorbency foams, gentle packing if necessary, avoid overpacking, and protect the peri wound aggressively. So, what do we stop doing when it comes to hospice? So, in hospice wound care, often we stop aggressive debridement, serial measurements, weekly photo documentation. I mean, I'm being honest, I would still do it, the weekly photo documentation and the measurements still. Wound progress grading, they usually stop that. Costly advanced biologics. Yes, they usually do stop that. Painful offloading devices. I think I saw something maybe a few years ago that they were doing certain biological skin grafts on patients that were in hospice, and I believe they got convicted of fraud in that case because they kept on overbilling. I think it was a Medicare thing. I'm not sure. Forgive me if I got the story wrong, but from what I got from the story, in conclusion, that they were just pretty much putting skin grafts, but a significant amount of skin grafts on patients that were in hospice care. So, if the treatment does not improve the comfort of the patient, it shouldn't really belong in hospice, okay? Because remember, hospice is comfort care. Is supposed to help improve the comfort of the patient, not distress the patient. Okay? As we know aggressive debridements are very distressing for the patient. Very frequent dressing changes are distressing for the patient. Odors are distressing to patients because patients notice it because it's from the wound, it's on them. So you got to think about that. So, medical ethics in hospice wound care. So, ethical principles are at play in hospice. So, autonomy, honoring the patient's wishes, beneficence, doing what is good. And I understand, I look up to the sky. Why is that not our number one goal? Doing good. Non maleficence, avoiding harm, and justice, appropriate resource use. So the ethical truth when it comes to hospice is healing at all costs can become harmful to the patient. So like let's say doing a painful debridement, that's not very helpful to a patient in hospice care because it's all about comfort. We're not saying we want the patient to become septic, but doing a painful debridement that offers no meaningful benefit to the patient is not ethical care. Next is you have to educate the family. Patients' families in hospice often ask, why isn't the wound healing? Did you do something? Is something wrong? Are they suffering? Shouldn't you be doing more? And the clinician's role is to normalize and make them understand exactly what's going on with the patient's wound, remove any blame, explain the physiology to the patient, and reframe success as comfort for the patient, especially if they're in hospice. So, in hospice wound care requires emotional intelligence, presence, also sometimes silence and acceptance. Sometimes the most powerful treatment is just to bear witness, to be emotionally intelligent and still make sure that your patient is treated with care, comfort, and dignity. So, in a quick takeaway, hospice in wounds, like in wound care with hospice care, wounds are not defined by failure. You have to treat the pain, treat the patient with comfort, to try to avoid the patient any suffering at all costs, okay? And make sure the patient has his or her dignity. Your role is not to close the wound, especially when it comes to hospice, because it could happen. If you're treating the patient well and the patient still wound closes, still a win-win, right? But in hospice care and wound care in hospice, it's about comfort, giving the patient dignity, and treating the patient's physiology. Is to protect the human being at all costs right now, okay, in hospice. So this has been Diabetic Profiles. I wish I went way more into another ulcer, but I'll do an episode on that. But has been Diabetic Profiles, where we talk about wounds honestly, ethically, and without fear. Because sometimes the most advanced care, is knowing when not to fight the body. Instead, just protecting the patient's soul, protecting the patient's dignity, and make sure that giving the patient comfort. This is Diabetic Profiles. This is Dr. G, and take care of your feet because they take care of you.